Hello, my name's Nikki Pullane. I'm the Director of Primary Care, and it's a pleasure today to talk about our primary care networks and developing the ICS in BLMK. And this is very much a session about seeking your views. So what will the ICS help PCNs achieve? Well, we all know it's about better outcomes for people, but let's look at that in a bit more detail. It really is to integrate systems to tailored personalised care and reducing that complexity and confusion that we're all aware of. It's very much to bring health and social care together with a wide range of partners, both statutory and voluntary. A better way, but harder way of working is collaboration, and we don't have illusions how difficult collaboration can be. But it is that shift to focus to well-being and prevention. So it's about all organisations taking that collective responsibility for improving the population outcomes and managing the resources, most importantly, to deliver those high standards. So what is our vision for the BLMK integrated care system? Again, we've said it's about improving the health and well-being of our population. And this really means that we're working to help people to live longer and healthier lives, because we want to increase the number of years people spend in really good health and to reduce that gap between the healthiest and the least healthy in our community. So, an example of where we're making a difference, the Silver Frailty Line. So a new pathway, which is unique to our Bedfordshire, Luton and Milton Keynes system, has been launched. It's the first of its kind in the east of England, and it allows paramedics, technicians from the ambulance service to join up with the frailty team at the hospital to secure specialist clinical advice when attending a frail resident. Frailty nurses are able to give their sound clinical advice to either support the person to receive care in the right place at their home, or if they do need to be conveyed to hospital, they can fast track them to a specialist frailty ward. And that basically means that our elderly people are not having to spend time in the A&E departments. This pathway provides both better care and it reduces the pressure on the emergency departments. So this is being held as an example of really clinical best practice. So our place-based partnerships, we have 4 places in our Bedfordshire, Luton, Milton Keynes ICS. We have Bedford Borough, we have Central Bedfordshire, Luton and Milton Keynes. And our ICS is based on this principle of subsidiarity, with decisions being made as close to the people and the communities as possible. So our new place-based partnerships will oversee and deliver a place-based strategy and plan. And the partnerships will be able to take on delegated functions from what will be the Integrated Care Board, shortened to ICB. And the most important thing is primary care networks are key members of the place-based partnerships with local authorities, with NHS trusts, and wider partners, including police, fire, housing, Health Watch, education and others. So we want to know what you think, and that's really, really important to us. And that's why we're inviting primary care networks and GPs to give us the feedback on 2 specific areas. The ICS governance. We really want to understand your views about the membership of the Integrated Care Partnership and the Integrated Care Board. And the other area is we want to hear your views about how we engage with GPs after the 1st of April 2022. And your feedback will help us to develop how we work together in the future as an integrated care system.
Thank you, Nikki. Let me introduce myself. My name is Rima McCarrum and I'm the chair of BLMK's Integrated Care System. I'm very pleased to meet you all. I'm going to follow on from what Nikki's been describing to explain what the ICS is for and how we're trying to organise ourselves and structure ourselves in readiness for becoming a legal entity from 1st of April next year. So on this slide, what's an ICS for? There are 4 core purposes of an ICS. The first is to improve outcomes in the population and in health and healthcare. To tackle inequalities, as we have seen, it is becoming a pressing issue. So tackle inequalities in the outcomes and the experience and the access to care that the population needs. The ICS will also enhance productivity across health and across care and other arenas, and improve value for money. And the ICS will help the NHS support the broader social economic development. As described in the legislation, integrated care systems are new partnerships between the organisations that provide health and care across an area, designed to coordinate services and plan in a way that improves population health and reduces inequalities. When we look at the wider determinants of health, those things that impact on an individual's health, you can see from this slide that only 20% of the health outcomes are determined by the clinical care that's delivered by GPs and NHS providers. And that will include access to care and the quality of that care. The remaining 80% is actually dictated by the health behaviours of the individual, whether they smoke, take enough exercise, drink, etc. What their socioeconomic factors are, so the level of their education, whether they're employed and their income, and the support around them, and the built environment in which they live, so the environmental quality and their built environment, the housing. So if we want to make a difference to our population in BLMK, we really need for the whole ICS and all its partners to concentrate action on all fronts. There are many new roles in the ICS as it becomes a legal entity. Up till now, we've organised ourselves as a partnership board, including CEOs, chairs and elected leaders across BLMK, and PCN reps and Health Watch. The legislation mandates that we organise ourselves differently. So at the centre, we've still got integrated care systems. At the centre of our purpose is still people and the communities that we serve. But there will be a number of different groupings and organisations within it. So at the top, we've got the Integrated Care Partnership, where all the partners working together will set the strategy for BLMK, and I'll come on to what that might look like. We then have place-based partnership. So place is defined in BLMK as the footprint of each of the local authorities, and therefore we have 4 places. We have Bedford Borough, we have Central Bedfordshire, we have Luton, and we have Milton Keynes. And the partners in those 4 local authority areas will work together to really refine the strategy that meets the needs of their local populations, their local neighbourhoods, and deliver services to shift population health outcomes. Then there will be provider collaboratives. These collaboratives might be vertical. It might be, for example, an acute working in a collaborative with community health and mental health. It might be across a sector, could be acutes working together, mental health working together. It can span a much wider geography. So, for example, our mental health providers already span the whole of East of England. Every acute and every mental health provider is mandated to be part of a collaborative. Other providers are encouraged to be part of a collaborative if it makes sense for the delivery of services. And then finally, we have an integrated care board. That will be the statutory organisation that will be responsible for making sure that the ICP strategy, the strategy defined by that partnership, is being delivered. And it will be responsible and accountable to NHS England for the quality, finance and operational performance of the whole system. However, it's still based on subsidiarity. What does that mean? That means that strategy is still defined at place. As much as possible will be delivered as close as possible to the population. So the ICB is going to be more of an operational and statutory body rather than the body that will be able to move forward at place level. So I mentioned the Integrated Care Partnership. This is yet to be defined, and therefore this is an area where we'd like your feedback. It is mandated that this partnership is defined as the partnership between the Integrated Care Board, which I'll come on to in a minute, and the 4 local authorities. But the membership of that partnership is permissive in the sense that we can have whoever we feel is right to be on that partnership, and should span a wide variety of stakeholders. So here is a draft proposal, but these conversations are only just starting, and we would really welcome your feedback. So the core membership would probably include all the NHS trusts, one PCN clinical director from each place in BLMK, all the local authorities and the social care services that they provide, the 4 BLMK health watches, police, fire, education, the criminal justice, housing, social care, voluntary and charitable sector, and the 2 directors of public health. It is possible that some of that core membership will flex depending on what's on the agenda for any one meeting. So, for example, if it's to discuss mental health, we might be inviting specific organisations from the voluntary and charitable sector that are experts in that field. So there will be a core and then probably some flexible membership so that we have the right conversations with the right people around the table. The Integrated Care Board, which you'll remember is the statutory board that has to answer to NHS England and show its accountability for how the system is performing. The membership of that is less permissive. So I've already been appointed as the chair designate. We are in the process of running a competitive process to recruit the CEO. And it is proposed that PMS ICB members will be nominated by GP practices in BLMK and appointed via an interview process to the ICB. I should probably state at this stage that we don't know how we can run this process. The guidance on this will be told to us fairly soon. We're still waiting for that guidance, so let's not get too hung up on that actual process at this point. It is a unitary board. For those of you who don't know what that means, it means that the people on that board do not represent their organisations. They bring skills, they bring experience, they bring knowledge of their sector, of the geography of BLMK, of local communities. They are appointed to the board as individuals, and therefore they have to meet the eligibility criteria. They will need to meet the fit and proper persons test. They will take on personal liability and accountability, as is what normally happens on a unitary board. And for this board to be effective, we can't have everybody at the board. There are limits on the numbers that we should have and that we will be allowed to have. So we are trying to work to a guideline of 15 to 18 board members. Once we've agreed between ourselves, and by ourselves I mean all the stakeholders, we need to submit our proposal for this membership to NHS England, who will then approve or not our proposal by the 17th of November. Once we have that proposal approved, we can then embark on the nomination and appointments process. And the next slide will describe what we're currently proposing as the membership. And again, we welcome your views on it. So the board member types, it has to have an independent chair. I've been designated as that chair. We need to have non-executive directors, mandated a minimum of 2. One person has to chair the audit committee, the other person has to chair the remuneration committee. We're planning on appointing 3. And the third person will bring skills and experience that maybe are not represented through the rest of the membership on the organisation. So those skills will need to be defined over time. There will be 4 executive directors, again mandated in the legislation, including the Chief Executive Officer, the Chief Finance Officer, a Medical Director and a Director of Nursing. And all of those 4 appointments are yet to be made. We then have a category called partner members or ordinary members. The legislation mandates that we have at least 1 person with knowledge of NHS trusts, at least 1 person from primary care or primary medical services, and at least 1 person from local authorities. We're currently proposing the following. We would have 3 people from NHS trusts, who hopefully between them will have knowledge of acute mental health and community health services. They will be either at CEO level or executive director level, and they are on the board not representing their organisations, but just bringing us the knowledge of their sectors. And collectively, we would like them to cover BLMK, so they also bring knowledge of the needs of their local communities. The primary medical services providers, we are proposing to have 2 from different parts of BLMK, with potentially understanding of very different types of communities, perhaps very urban and deprived, and more rural and more affluent, for example. Our 4 local authorities would be on the board, but not representing their councils, but representing the needs of their local populations with the knowledge of their population health data. So those would make up between them 17 board members. And then the final category are participants. These individuals would have the right to attend meetings, the right to participate, but unlike the previous members, would not have a right to vote. I would hope that we would never need to vote. It should be a last resort. And here are some suggestions of the type of participants we might have. We would have both directors of public health. We may have other ICB executive directors, including the workforce director, depending on what's on the agenda. And we are also proposing that we may have up to 2 associate non-executive directors that we wouldn't recruit to at this point, but it would allow us to improve the diversity of the board by potentially putting people in those roles who have the potential to become full non-executive directors in the course of time, that have yet to develop their experience and their skills to be able to deliver that role. And they may come from non-traditional backgrounds, they might be very young and not yet embarked on a full career. It could be all sorts of people, but it gives us an opportunity to train people up and address the whole EDI agenda even better. So that's where we're at the moment, and your views are very, very welcome. And at this point, I will hand over to Maria Wogan.
Okay, thank you, Rima. My name's Maria Wogan. I'm the Programme Director for the establishment of the ICS in BLMK, and I'm just going to take you through the last few slides of this presentation. So let's just focus on what's going to happen from the 1st of April 2022 in terms of what the changes mean. Firstly, the BLMK Clinical Commissioning Group will be dissolved as a statutory organisation. We will still have, within the 4 boroughs in BLMK, 4 place-based partnerships, and over the next few months we'll be working together to define in greater detail how these place-based partnerships will work, and what the membership will be, including how the primary care networks play their role within the place-based partnerships. We'll be establishing an integrated care partnership, as Rima described earlier, and establishing the integrated care board, which we've just talked about. The staff and the functions from the BLMK CCG will transfer to the BLMK Integrated Care Board on the 1st of April 2022. So what do the changes mean for general practice? In the main, there will be no change that you will experience in your day-to-day work. NHS England will continue to hold your contracts as they do now, and day-to-day management of those contracts will transfer to the staff that you already work with in the CCG, who will have transferred to the new organisation, the Integrated Care Board, the ICB. So the staff that you have relationships with and that you work with really well at the moment will carry on being your key points of contact and the people that you carry on working with from the 1st of April, as they will be transferring into the new organisation, the ICB. You'll continue to receive regular information and support from that team as you do now, and the Integrated Care Board will continue to engage with general practices via the PCNs and the other forums that we have for GPs. And we want to come on and talk about that in a moment to hear your views on how we can develop that better. The Integrated Care Board will retain a governance forum for primary care commissioning. At the moment, it's not clear what the requirements in terms of the legislation will be for that governance forum, but we are committed to continuing a forum, and when we understand what the requirements are, we will work together with yourselves to develop that for the new organisation. Some of the key changes are to the Integrated Care Board, it being a different forum to the CCG. It has a wider range of health and social care partners as members, and that is to support the integration of health and social care. Also, the Integrated Care Board is not a membership organisation, so that is a change in terms of what that means for general practice. So, as a new organisation, we're keen to work with you and hear your views on what's the best way in which we can engage with yourselves within primary care to work together to deliver better outcomes for our population in BLMK. We know we'll no longer be a membership organisation, but it's really important to us that your clinical voices and the voice of your staff working at the front line of primary care feed into the work that we're doing and the way in which we're going to transform services together. So our plans are to continue to engage with GPs and primary care colleagues through the weekly GP bulletin, attending your PCN and practice meetings, the regular PCN-CD meetings that take place. We also meet regularly with the LMCs. We intend to continue holding BLMK-wide GP meetings and place-based GP meetings. Also, the PLT sessions will continue when we're able to reinstate them when operational pressures ease, and other GP forums will be established. We also plan to engage further by recruiting GPs to our clinical networks and working with GPs to co-produce clinical pathways across the system. What we'd like to know from you is your ideas of how we can improve our engagement with GPs and primary care colleagues to really deliver meaningful change within our system, and we hope you'll respond to this engagement exercise by sharing your views on that. So, in conclusion, just to round up the areas that we're interested in hearing your views and really welcome your feedback. In today's presentation, we've asked your opinion on the proposed membership of the Integrated Care Partnership. Have you got thoughts you'd like to share with us around who you think should be part of that partnership, setting the strategy for the population of BLMK? Also, what are your views on the membership of the Integrated Care Board? So that's the statutory organisation that's responsible for delivering the strategy set by the partnership and providing that regulatory role. What are your views around our proposals for board membership, particularly from primary medical services? And finally, how can we work with you better going forwards to engage GPs and primary care and make sure that your voices are heard in the work of the integrated care system? We're holding some briefing sessions on the 21st of October and the 2nd of November that are open to all primary care colleagues to join. They start at 6:30 and will run for an hour, and we really hope that you'll be able to join us and share your views and have a discussion with us about these new developments for our system. We're also providing a feedback form along with this video to help you feedback your views and let us know your thoughts on these proposals. And we'd be grateful if you could return that to the email address indicated on the slide by the 3rd of November so that we can take your views into account. In terms of next steps with this work, it's very much a developmental and co-production piece of work for us over the next 6 months. So this is the beginning of our conversations and not the end. We've got the briefing sessions coming up that we hope you'll be able to join us. We've also published on our CCG website the draft constitution for the Integrated Care Board, so that if you're interested in looking into that document, it's there for you to see and to give feedback to us on. We also have regular meetings set up with the LMCs to discuss the development of the ICS and the constitution. And your LMC representatives are members of our steering group, steering the programme to set up the ICS in BLMK. We also have 4 PCN-CDs who are members of the ICS Partnership Board and have the opportunity to take part in decision-making around the future establishment of the ICS. Sarah Whiteman, the chair of the CCG, is arranging clinical conversations over the next few months for primary care colleagues, which will focus on the ICS and the difference we're trying to make for our population. In terms of the feedback on this particular piece of work, we will feed your thoughts into a partnership board meeting taking place on the 3rd of November, where we hope to come to a conclusion around the membership of the ICB and continue our conversations about the development of the Integrated Care Partnership and how we engage with primary care going forwards. Thank you very much for taking the time to watch this video and take part in this engagement exercise. Thank you.